Hello, this is genetics on the non-Mendelian disorders presented by the SchrDbb with reference ABC of Clinical Genetics by Helen Kingston. So, here we're going to visualize other diseases which are not transmitted by Mendelian pattern. So, we need to know that these other diseases which are not transmitted by Mendelian pattern can be of different inheritance method, but usually they can depend both on genetics and environment. From other diseases which are not inherited by Mendelian pattern, at the level of the environment, you can have infections, you can have infections, you can have congenital heart disease, you can have infection and congenital heart disease are more of environmental than genetics. So when you have congenital diseases and infections, they are more of environmental. Diabetes is in the middle of both environmental and genetics, and then genetics. In genetics, you have more of schizophrenia, even diabetes. So those are the disorders which are not transmitted by Mendelian pattern. So we start with the first inheritance method, non-Mendelian inheritance method, which is multifactorial inheritance. So the concept of multifactorial inheritance implies that disease is caused by interaction of several adverse genetic and environmental factors. Is it clear? So in multifactorial, that particular disease or disorder is not only genetic like Mendelian pattern. Is it clear? It can be genetic and environmental, both coming together to do that disorder. Is it clear? So as you can see here, these are the different environmental factors, and there are different environmental factors and genetic factors that can come both together to cause a multifactorial inheritance method. Like environmental factors such as trauma poisoning, you have teratogenic defects. Is it clear? They are located here. While in genetics, single gene disorders are mostly genetics. Coronary heart disease, the more you are going to coronary heart disease, the more you are going to neural tube defect. They are more of environmental. Teratogenic defect are more of environmental than genetic themselves. So these are multifactorial disorders. So in multifactorial disorders, you see that what there is. So this is the genetics. So you see the affected population increases. So this is only because of the gene. Is it clear? So in the hypothetical diagram, the genes only account for this, and when you add up now multifactorial effect like the environment, you see more of the population is going to be affected. The incidence increases. Is it clear? So when you only have genes involved, the incidence is low. Why? When you have genes and you have environment causing a disorder, the incidence of that disorder is going to be higher. So those are now this is the risk of developing example Hirschsprung disease. So Hirschsprung disease is an example of disease which comes from a multifactorial inheritance method. Is it clear? So the Hirschsprung disease is divided into two. You have short segment Hirschsprung disease and long segment Hirschsprung disease, having ratios epidemiology in males and females. Is it clear? So Hirschsprung disease, you see that what in brothers and sisters, the brothers are going to have more Hirschsprung disease than sisters in a ratio of 4:1 in case of short segment Hirschsprung disease. And long segment Hirschsprung disease, you see also that the ratio is becoming lesser, like in a ratio of 2:1 for brothers and sisters. So those are the percentage risk to be transmitted. More males are going to have Hirschsprung disease compared to the females. It's not a half to half percentage like in case of single gene disease. So for multifactorial disease, when you want to calculate the risk for one patient to have that disease or one patient to have that allele, is it clear? You calculate the risk based on certain probability that has been calculated in the past. Is it clear? So we see that on the Hirschsprung disease, you see that it is going to be more common, like in this multifactorial inheritance disease. In multifactorial inheritance disease, it is going to be more common in females than in males, or is going to be more common in males than in females. There is a sex which is more preferential in multifactorial disorders. Is it clear? As compared to autosomal disorders. In autosomal disorder, the only time where the sex is predominant is when you have X-linked diseases. And when you have X-linked diseases, it's only the males that are most at times affected. Is it clear? But here in multifactorial diseases, here at times it may be the males that are affected more predominantly, at times it's the female that is affected more predominantly. Is it clear? So when you have this type of disorder where with a discrepancy between the males and female affected, just think of multifactorial disease. So the example is Hirschsprung disease, which has a higher effect on males. Another example can be pyloric stenosis, which is more in males in a ratio of 4:1. Is it clear? So all these are multifactorial diseases. So risk of recurrence. So that is what was on risk of recurrence. So what are the factors increasing the relative multifactorial disorders? You have one, high heritability or heritability of disorder, because said that it consists both of genetic and environmental pattern. So we have close relationship to index case. 3, we have multiple affected family members, so it increases the risk of multifactorial disorders. You have severe disease in index case, and then you have index case being of sex not usually affected. So what are the estimated heritability of different diseases? So all these are diseases with multiple factorial inheritance, but certain diseases are more heritable than others. And before going to heritability, let's first have a definition of heritability. The heritability of a variable trait or disorder reflects the proportion of variation that is due to genetic factor. So that's easy as that. So as easy as that is that what it is the ability of you to inherit a disease, a particular disease. That's heritability. Is it clear? So in that heritability, schizophrenia has a very high heritability, then asthma, then cleft palate with cleft lip, then coronary heart disease, hypertension, neural tube disease, peptic ulcer. So those are the heritability. So peptic ulcer is going to depend more on environmental factor than hereditary, while schizophrenia is less of environmental factor and more of hereditary. Also, what they are forgetting here is alcoholism. Alcoholism can work with schizophrenia. Alcoholism has more of heritability than environmental. Is it clear? So we have also HLA association and linkage. So HLA association and linkage. So we have several important disorders occur. That's the human leukocyte antigen. Several important disorders occur more commonly than expected in subjects with particular HLA phenotype, which implies that certain HLA determinant may affect disease susceptibility. So HLA, the human leukocyte antigen, are actually histocompatibility antigen. Is it clear? And this histocompatibility antigen, which is divided in MHC class 1 and MHC class 2, that's major histocompatibility class 1 antigen and major histocompatibility class 2 antigen. Both of them are involved mainly in immunity. Is it clear? And this disorder which are involved with immunity, with major histocompatibility type 1 and type 2, they are examples of these disorders with the major histocompatibility disease type 1 and type 2. Major histocompatibility disease type 1 and type 2, the disease involved there, we have the first one, ankylosing spondylitis. Is it clear? The second one is autoimmune thyroid disease. The third one is chronic active hepatitis. The fourth one is celiac disease. Fifth one is diabetes. These are the different genes involved. The sixth one is hemochromatosis with the gene involved. Multiple sclerosis, psoriasis, Reiter syndrome, and rheumatic arthritis. So all these diseases are associated with the HLA gene, and the HLA gene have all of these different genes under it. Is it clear? So HLA antigen have all of these genes which can produce that antigen. Is it clear? And the result to this different disorders. So from here you see that diabetes, the juvenile diabetes, is because of the histocompatibility complex. Is it clear? Now you also have twins. So we have said already that twins, in order to consider twins, you consider dizygote twin as one single twin, and you consider dizygote twin as two different brothers and twin sisters, and you consider monozygote twin as one twin. Here twinning, so dizygote twin may be familial, more common in black people than white Europeans. So we have dizygote twins again more in blacks than white. Is it clear? Like they are also called fraternal twins. And monozygote twin is seldom familial. So what is inherited is more of monozygote twins. Is more familial. So what the race form, the one which is based on the race, is dizygote twin, but what is inherited, for which what is more familial, is monozygote twin, occur in 0.4% of all pregnancies. So associated with twice the risk of congenital malformation than a singleton or a dizygote twin pregnancy. So that this monozygote twin is more of a pathology than a normal physiological condition in pregnancy. Now diabetes, there are three main types of diabetes that you have to know. There is type 1 diabetes, which is insulin dependent. There is type 2 diabetes, which is non-insulin dependent, and there is type 3 diabetes, which is maturity onset diabetes of the young. Is it clear? So developing, so maturity onset diabetes of the young. Diabetes of the young, which is normally supposed to develop at old age. That's maturity onset diabetes of the young, also called MODY. So this MODY, so insulin dependent diabetes mellitus, you need to know that usually occur in a ratio of 3 in 10,000 people. So 3 in 10,000 people, and this is because of a problem with the HLA gene. So because of the HLA antigen, the major histocompatibility antigen, that is having a disorder. So you are going to have an autosomal, you are going to have an autoimmune reaction. And that autoimmune reaction, because of an abnormal HLA antigen of the islet of Langerhans, you are going to have an autoimmune reaction where autoantibodies are going to be produced against the cells of the islet of Langerhans, and then they are going to destroy it, making that the body do not produce insulin, and then it requires to be injected insulin for glucose to be transported to the cells. So that is the thing. So in insulin dependent, usually you have ketosis, while in insulin non-dependent you have no ketosis. Is it clear? Because insulin is the presence of insulin inhibit the production of ketones. The next one is that we are going to speak about. The next one that we are going to speak about is the next diabetes. So we have insulin independent, non-insulin dependent diabetes, non-insulin independent diabetes mellitus. So in non-insulin dependent diabetes mellitus, you need to know that what the non-insulin dependent diabetes mellitus is even more non-insulin dependent diabetes mellitus is even more genetic than, is more inherited than the insulin dependent diabetes mellitus. So you can see that in this table. So this is the empirical risk of diabetes according to the affected members of the family. You see insulin dependent diabetes mellitus, the siblings, you see the risk is 16%, both parents 4%, monozygote twins is 30%. You see monozygote twins are having non-insulin dependent diabetes in only in 30%, while in non-insulin dependent diabetes mellitus, you see that monozygote twins, they are having 40 to 100%. First degree family issue is 10 to 40%. It means that the non-insulin dependent diabetes mellitus, which is the maturity, which is the old age adult diabetes mellitus, is more inherited, more genetic than insulin dependent diabetes mellitus. Is it clear? And then the last one is maturity onset diabetes mellitus of the young. You see the first degree family issue is 50%, so it is the most inherited. So the most inherited is maturity onset diabetes of the young. The second one is non-insulin dependent diabetes mellitus, and the next one is insulin dependent. So maturity diabetes or maturity onset diabetes mellitus is just like the type 2 diabetes mellitus, which is inherited in young individuals. So what are the factors indicating increased risk of insulin dependent diabetes? So we have insulin auto antibodies, isolate of Langerhans antibodies, you have activated T lymphocyte, and you have specific HLA haplotype. So the prevalence of non-insulin dependent diabetes mellitus is increasing worldwide, and it has been estimated to be 250 million people in the year 2020. Now, coronary heart disease. So what are the risks of coronary heart disease? Generally, in all the environmental risks of coronary heart disease can be just given with the mnemonics HEART. H for hypertension or high blood pressure, A for age, is it clear? A for age, and A also for alcoholism, D for diabetes mellitus and dyslipidemia, S for stress, smoking, or sedentary lifestyle, is it clear? You can also have D for diet, is it clear? So that is the mnemonics that can be used in case of environmental factor. Now, for genetic factor of coronary heart disease, you can have family issue of coronary heart disease. It's also very important in coronary heart disease. You have lipid abnormalities like LDL and apolipoprotein A, B, E disorder. Those are dyslipidemias. So dyslipidemias, and also have this. So those are the different cases. So these are the type of hyperlipidemia. So the types of hyperlipidemia, like in case of dyslipidemia, you may have autosomal dominant disorders. You can have autosomal recessive hyperlipidemia. You have polygenic hyperlipidemia. Now, autosomal dominant hyperlipidemia, you have familial hypercholesterolemia, which is in WHO class 2 and class 3. These are the WHO classification of the different hyperlipidemias. In familial hypercholesterolemia, you have a very high level of LDH. In familial combined hyperlipidemia, you have both high LDH and high very low density lipoprotein. You are in familial hypertriglycemia, you have very high, very low density lipoprotein, and you have very high chylomicrons. These are autosomal dominant disorders resulting in dyslipidemias. Now, autosomal recessive disorders, we have apolipoprotein C2 deficiency. In apolipoprotein C2 deficiency, normally what is the role of LDH? LDH is used in transmitting cholesterol, triglycerides, but it's more of cholesterol which are being transported in LDL. VLDLs are used in transferring cholesterols and triglycerides both together. That's why it is said to be combined hyperlipidemia, because it contains both cholesterol and triglycerides. So LDLs and VLDLs are transporting cholesterols and triglycerides. But now, when you have familial hypertriglyceridemia, so it's only VLDLs and chylomicrons. Chylomicrons only transfer triglycerides. Is it clear? Chylomicrons only transfer triglycerides. So that's why it's mostly involved with a very high level of triglyceride level. So see high level of chylomicrons. Is it clear? Now, in apolipoprotein, now we need to know that, but what is the role of apolipoproteins? Apolipoproteins are used in order to transport triglycerides from blood into cells. Is it clear? Cells of the body. Are you getting? So when you have high level of apolipoproteins, those apolipoproteins are going to transfer triglyceride from the blood to the different cells of the body. Now, when you have apolipoproteins deficiency, it means that what? The triglycerides are not going to be transferred from the blood to the cells. That's why you are going to have high level of triglycerides in blood, and these triglycerides are transferred in chylomicrons mainly, and are also transferred in very low density lipoproteins. So you're going to have excess of both of these two, basically. Now the next one is polygenic, that is common hypercholesterolemia. I've said that cholesterol is mostly transferred in low LDLs, in low density lipoproteins, so that's why you have high level of LDLs in case of common hypercholesterolemia. Is it clear? So those are the different disorders, and this disorder can give rise to atherosclerosis, and that atherosclerosis can be at the level of the coronary artery, resulting to a coronary heart disease. Now schizophrenia and affective psychosis. Now schizophrenia, so this is a preclinical presentation first of hypercholesterolemia, where you are going to have xanthelasma. Xanthelasma is lipid accumulation at the level of the eyelids, so that is xanthelasma. Now schizophrenia and affective psychosis. So it is, we said that schizophrenia is more of genetic than even environmental. So there is a strong familial tendency in both schizophrenia and affective disorder. Is it clear? So what are the overall incidence and the empirical risk of recurrence of schizophrenia and affective psychosis? Now you need to know that schizophrenia, the siblings who have one, so monozygous twin, you see, is 40%, showing you that schizophrenia has a very high tendency of being inherited, and family degree relationship 1 to 2. Is it clear? So that is it. Now in case of 1 to 2, it means that the third degree family relationship are not going to be very affected with schizophrenia, but the first degree family relations at the level of the monozygous twin are very affected with schizophrenia. Is it clear? Now affective psychosis. In affective psychosis, it is even in monozygous twin is going to be even more inherited, like 70% of cases. Is it clear? But in third degree family relationship is going to be very small, 2 to 3%. Now congenital malformations. So what are the risks of recurrence of congenital malformation? So congenital malformation are not genetically inherited. They are more of environment. They are multifactorial, meaning that they are more, and they are even more of environmental. Is it clear? So like in case of anencephaly, when you have lack of vitamin or folic acid in the first trimester, so it can result to, and the recurrence rate is only 5%. Congenital heart disease, recurrence rate is only 1 to 4%. Cleft lips, cleft palate, renal agenesis, these are the different recurrence rate. So pylori stenosis have a higher recurrence rate, and we have congenital dislocated hips also have a high recurrence rate. Cryptorchidism and hypospadia have high recurrence rate. Now mental retardation and learning disabilities. Is it clear? So there are certain disorders, genetic disorders that result to mental retardation and learning disability. And we said that the most common cause of a single gene disorder resulting to mental retardation is Fragile X syndrome. So that is the answer. But now for multifactorial gene disorder, there are other causes of mental retardation. So there are different causes of mental retardation here. So these are X-linked. You can have X-linked disorders which are observed with mental retardation, and that mental retardation is based on the quotient, intelligent quotients. So when you have an intelligent quotient of less than 50, you said to be, you are told to be mentally retarded. Is it clear? So there are different diseases involved with that. So from here we are finished with the diseases involving multifactorial inheritance. So say thanks for your kind attention. Don't forget to like and subscribe.